Welcome back. So, as colorectal cancer is now one of the fastest rising cancers in adults under 50, there is growing urgency to address gaps in early detection, beginning with reevaluating Canada's current screening guidelines. Recent policy advancements in breast cancer, specifically the lowering of the screening age to 40, have really demonstrated how emerging data and advocacy can accelerate reform. This shift has helped to catalyze calls to action to apply the same urgency to colorectal cancer, wherein arguably, there really are more troubling trends in younger populations, but the tumor type has yet to see parallel policy movement. CRAN has been advocating for quite some time for the screening eligibility age to be reduced as early detection saves lives, and we believe we are making some progress. Our first panel discussion of the symposium is entitled A National Priority, Lowering the Screening Age for Colorectal Cancer. I am pleased to welcome back Dr. Michael Rafel, medical oncologist and young adult colorectal cancer clinic lead at Sunnybrook Odette Cancer Center, who will moderate this discussion. Dr. Rafel is joined by Amanda Conlin, co-founder and executive director of the Circle Back Foundation, who will be rooting the discussion with her lived experience and perspectives after losing her cousin to early age onset colorectal cancer. Joining the panel, we welcome Dr. Aparna Parikh, director of colorectal cancer, medical oncology research and young adult colorectal cancer at the Mass General Brigham Cancer Institute in the US. Dr. Darren Brenner, Armstrong investigator in molecular epidemiology from the University of Calgary, who holds multiple directorship appointments for screening programs in Alberta. Dr. Usman Hamid, colorectal surgical oncologist and clinical lead for the GI cancer program at North York General Hospital. And Dr. Gary Wild, a senior gastroenterologist and professor and program chair at the McGill University Health Center. Welcome to all of our panelists, and Dr. Rafel, I'll turn it over to you.
All right. Hello, everybody. A great day indeed for a symposium, a great day indeed to talk about lowering the screening age for colorectal cancer. This really needs to be a national priority. And I'm so thankful to be joined by such an amazing group of co-speakers to discuss this. And so I've been asked just to keep the introduction relatively brief because I'm the least important person you should hear from. We need to hear from the other experts. And I'm just going to show you, if I am adept at all these years of Zoom, one slide to illustrate the importance of this talk. So I'm going to share my screen and I'm going to I'm no longer adept at, I've destroyed my screen, guys. Okay, so suffice to say, I was going to show you a screen from Dr. Brenner, who has done amazing epidemiological work in Canada to show that really we are in the midst of an epidemic. While we've been quite successful in reducing the incidence of colorectal cancer among patients over the age of 50, there has been a dramatic increase in the incidence of colorectal cancer under the age of 50 for men and women. And of alarm, as I talked about in my talk in the past half hour, we see this birth cohort effect where the more recently you were born, the greater your risk is of early age onset colorectal cancer. And unfortunately, patients who are born in the 1980s now have double the risk of early age onset colorectal cancer compared to compared to their parents' generation. So we need to do something about this. And that's why one of the major priorities of the symposium is to discuss the recommendations and the reasons why we might consider lowering the screening age for colorectal cancer. And so to start, I would like to ask Amanda to, share her experience as a caregiver to her late cousin and to help us understand from her perspective how things could have turned out differently. Could there have been early access to screening and a timely diagnosis, and speak to her amazing efforts in advocacy for early screening as part of the Circle Back Foundation.
Thank you so much. Good morning, everyone. My name is Amanda Conlin, and I'm here because my cousin, Adam June, died after his battle with colorectal cancer. We spent our whole lives side by side until we didn't. Adam was 44 when everything changed. He started having symptoms that just didn't feel right. Digestive issues, bleeding, pain he couldn't explain, and he did all the right things. He saw his family doctor, he asked questions, he tried to advocate for himself. But unfortunately, it didn't work. Because he was under 50, colorectal cancer wasn't considered. His symptoms were interpreted as stress, IBS, hemorrhoids, anything but the thing it actually was. By the time another possibility was considered, the cancer had already spread. He was finally diagnosed with stage 4 colorectal cancer that had metastasized to his liver and his lungs. And 9 months later, Adam was gone. 9 months, a whole life, a husband, a son, the funniest person in any room, taken in less time it takes for most of us to plan a vacation. Even in those last months, though, Adam's heart was set on one thing. He wanted everyone to get screened. He said, if this happened to me, it can happen to anyone. Please go to the doctor. So we did, or at least we tried. His family, his friends, all of us showed up in our doctor's offices asking for colonoscopies or FIT tests. And what we heard over and over again was, you're not old enough. You don't need to be screened yet. You can't get a test without symptoms. Some of us were told to wait until we were 50. Some of us were told testing wasn't permitted at all. And some of us even had colonoscopies booked and then canceled because we didn't meet the criteria. Even after watching Adam die, we still couldn't access screening. And this just isn't Adam's story. We know it's happening across this country. Early onset colorectal cancer is rising quickly in younger adults, yet screening guidelines still focus on 50 to 74. This means younger people can sometimes be overlooked, not because physicians don't care, but because they're working within a system and guidelines that were created before this shift in younger patients was fully understood. Family doctors carry an enormous amount of responsibility across every age and condition, and they rely on the best evidence available to them, evidence that hasn't fully caught up with what we're seeing today. It's not a physician issue, it's a systems issue, and that's why it's so important to update the guidance and support available to them. So, in our grief and our heartbreak, Adam's wife Samantha and I created the Circleback Foundation to honor Adam's life and to help change the system that failed him. We started with nothing but pain and determination and a clear purpose. No one else should die because they were considered too young to get colorectal cancer. Today, Circleback Foundation focuses on 3 areas that Adam cared deeply about. Number 1, listening to young adults. We tell people, if something feels wrong, don't ignore it. Don't downplay it. Push even when it feels uncomfortable. Your life is worth the discomfort. Number 2, challenge the idea that this is an older person's disease. It isn't. Adam was not too young to be diagnosed with colorectal cancer, and neither are the thousands of Canadians under 50 now being diagnosed. The system just hasn't caught up with the reality of early onset colorectal cancer. And 3, advocating for earlier and easier access to screening. People under 50 should not have to struggle for testing. Physicians should be supported with clear, current guidelines. Families should never again be told to come back in 10 or 15 years after losing someone in their 40s. We're pushing for symptom-based screening that's accessible, automatic, and barrier-free, so no one falls through the cracks the way that Adam did. And finally, we fund research focused specifically on early onset colorectal cancer. What's causing the rise? What are the patterns? What can actually save these lives? Because this wave of young patients is not a blip, it's a trend, and it's a dangerous one. And until we understand it fully, we can't stop it. Adam wanted people to get screened. He wanted his story to save someone else's life. He believed right until the end that change was possible. So that's why I'm here today, why Circle Back Foundation exists, why we keep showing up in rooms like this, to make sure no one else is turned away, to make sure physicians have the support and information they need, to make sure families don't have to grieve the way that ours has. This is for Adam and for every person who deserves to be screened in time. Thank you.
Thank you, Amanda, and thank you for sharing your story and your experience and the advocacy that you have implemented to honor your cousin's memory. Because as I said before, I think that if we accept the situation as is, it's unacceptable. The current status quo as it relates to recognizing and diagnosing early age onset colorectal cancer and early onset cancers in general needs to change. I share your experiences. I am obviously a huge advocate of early age screening. I myself have had 2 screening colonoscopies, and I have the benefit of being a physician who can reach out to colleagues and say, hey, can we get this done? But I recognize that that's a privilege and that patients and family members do not have that same access. So we need to make sure that everybody has it as easy as that. And so, as I mentioned earlier, I'm the least important person here. I'm just here to help moderate and bring you the experts' point of views because, as Cassandra had introduced, we have an amazing panel of experts today. So I'm very much excited over the next, looks like we've got till just before 11:30, so shy of an hour, to hear from our amazing panelists. So we have some questions that we want to discuss and to guide some of the important topics that we're going through. And Cassandra's keeping her eye on the chat box because we do want to hear from the audience and hear about the important questions that you have because you are the ones who are going through this with your own lives, your own family, and so you are the most important people in the room. So we'll start off first with our colleague, Dr. Parikh. And so, Dr. Parikh, the US has lowered the average age colorectal cancer screening to 45, ahead of Canada. We are still stuck at 50. From your experience in the United States, what sort of key lessons, successes, unintended challenges should Canada consider as it evaluates similar changes? And in particular, I'm interested to learn, have you noticed any changes in your practice related to the earlier screening processes?
Yeah, so thanks so much for having me. I mean, this is such an important topic, and when you all asked me to do this, I, felt like I absolutely needed to be here to advocate for this. I think there are very few. There's a couple things that keep me up at night, and this is one of the things that keeps me up at night in terms of what is happening. So, as you mentioned, Michael, I think we're really lucky that the screening age did. Get lowered to 45. And when you look at the data, actually, many patients are having symptoms for, even like more than a year, actually, before they even come to attention. So I think first for this audience, we do need to separate symptomatic and screening, right? Screening is 0 symptoms. And you would be incredibly surprised how many we are just seeing asymptomatic patients that screening has picked up, which is incredible. But then again, there's the problem of the patients because they're younger. In our worlds, when we treat GI cancers, everyone has colon cancer when they're young with any small, symptom. But you have to understand from the primary care or GP perspective, and overall incidence, it's still not, in a primary care office, if you're looking at 100 patients coming in, the likelihood of a younger patient having a cancer is still very low. And so part of what the screening change did was also, I think, highlight the problem for the GP community so that their radar was turned on a little bit more, that independent of screening, you should have red flags and the alarm bells should ring before you say, oh, you're in your 30s, you don't have cancer. This is just hemorrhoids. This is just IBS. You're stressed. These are all things we hear time and time again. And again, that there's that diagnostic delay, up to a year for many patients. So I think not only has screening has actually impacted finding a stage shift with earlier stage patients, which is what we want. We know that earlier does matter for colorectal cancer survival outcomes. But I think the awareness piece was also really important because, some PCPs are hearing, oh, 45, and then they are now paying attention more and more to the younger patients who are coming in with symptoms that are not screening eligible.
No, it's super interesting to hear the insights from the American system, and we sort of have this perception in Canada that in the American healthcare system, if you have money, everything flows. But it sounds like even with patients who, come from high SES backgrounds, there's still a knowledge gap, and there's still an opportunity to improve access to early age onset screening. And I think it's so important the piece you mentioned about education. You know. I recently was at a debate with, we won't use any names of the university, but it was the home of evidence-based medicine. I was giving a debate against the GI doctors in Canada, the home of evidence-based medicine. You can all figure out where that was. And when we were talking about, looking for a diagnosis of colorectal cancer, a very nice older gastroenterologist put up a slide showing that if someone has abdominal pain, then they are extremely unlikely to have a diagnosis of colorectal cancer. And I said, so you're gonna just opt away from doing a colonoscopy in someone because they present with abdominal pain? Like, so there's all these sort of things that exist in our system that make absolutely zero sense to any of us. Yet they're quoted as rationale for why we should or shouldn't do interventions. But anyways, that was just my experience. Moving on, we will talk next for a question for Dr. Darren Brenner. Darren, you've produced numerous publications, some of which I highlighted in my talk before, that are talking about the alarming epidemic of early age onset colorectal cancer. And so based off of the epidemiological patterns that you're observing, what is the most compelling evidence that you can suggest to support us shifting to earlier age of screening?
So thanks for the chance to be part of this really important session. So for the past 9 years now, we've been sort of evaluating and modeling what the impacts are of early onset colorectal cancer in Canada. And so to your question, I think we've sort of identified what are the key pieces of information that specifically policymakers should be paying attention to, and what are those most compelling pieces of evidence to support a shift to earlier screening. So I thought I'll use the next just few minutes quickly to cover what I think are the 3 sort of key points that policymakers across the country should be aware of or paying attention to. And so the first kind of key point is, what are the actual data here in Canada and what do they tell us? So every year when the new data are made available, we update our models, and we really hope to not see that data point creep higher, but sadly that continues to be the case. And so when I speak to some of the people in different provinces and even people within screening programs, they say, well, yeah, but we're still not as high as the United States. And that's not the case. So the rates in nearly every Canadian province are now where they were between 2015 and 2016, which is when the United States first had the American Cancer Society put out its recommendation that was followed by the Preventive Services Task Force and then the AGA. So we are right now what was sounding alarm bells in the United States. Certainly, screening is administered by the province, and so provinces have different rates. There is an east to west gradient, with Atlantic provinces and Quebec having higher rates, but nearly every province is where the US was as it started to mobilize and have action. And so, as noted before, when we look at the comparison between millennials and Gen Xers in Canada and those born in previous cohorts, the age-specific rates are, twice as likely to be diagnosed with CRC than their parents' generations were. So what we see here, so this sort of first key point, the rates are the same level or higher where they were in the United States that led to action now more than 5 years ago. And so then I think the second key point is, well, okay, if rates now are where they were in the US pre-action, what can we learn from the United States after their changing of screening? And it's really positive. A lot of recent data, now it's been enough time has passed, that the early data suggests that lowering screening to 45 is working both from a clinical perspective and a population health perspective. So there's been some really large studies coming out of the Kaiser Permanente group in the United States that show if we use FIT as an index test, the positivity rates amongst the 45s to 49s are basically the same as they are in 50-year-olds. Amongst those people who then have a positive FIT test and go for colonoscopy, the yields, so what the findings in those colonoscopies are nearly identical to those in the 50 to 54 age group. So that suggests that that's an appropriate use of those, limited resources clinically if we're still seeing the same rates in that expanded age population. And perhaps then most importantly, the early data suggests that screening uptake in those less than 50 is starting to show sort of early indications of reductions in adenomas, CRCs, and earlier stage diagnoses in the cancers that are being diagnosed before age 50. So all the early data point to successful and positive impacts from lowering to 45 in the United States, while really not impacting screening outcomes or screening uptake amongst those over 50. And then the third, I think, key point specific to Canada is, okay, so we know this. What if we did start screening at 45 starting next year? And so we did lots of modeling to suggest what would be the impact in terms of population health and clinical resource impact. And so we've been building lots of models to understand if we did implement FIT-based index screening, followed by colonoscopy for those that are positive. We ran simulation models over many million people, looking at the entire Canadian population, and then projected out over the next 50 years of cohorts of people who would become eligible and then would enter screening, have their screening journeys, and then exit, and then looked at the impacts. And so our models suggest that this change, if we were able to do this in the next few years, would lead to over 15,000 fewer cases of colorectal cancer and over 6,000 fewer deaths over the next 3 decades. And so because a lot of this impact would happen in younger age cohorts, it would also have a major population health impact in terms of the potential years of life lost, because these are earlier diagnoses that are being made. And, in contrasting to the United States, we unfortunately live in a very constrained healthcare system here. So the big question is always, how much would it cost? So indeed, there would be a large expansion of the screening related costs. But given how costly managing late stage treatments and late stage colorectal cancers are, the net result would be a net cost savings of over $200 million over the next few decades. So to summarize those sort of key 3 points or 3 key pieces of data for policymakers, we are where the US was when they started making a change. All the preliminary data in terms of the screening impacts in the US suggest that there's a considerable population and appropriate clinical benefits. And the third is that our models and projections here using specifically Canadian data suggest that a change would prevent thousands of cases and deaths and actually lead to a net cost savings over the next few decades.
Yeah, I mean, the work you've been doing, and Aaron, is amazing. And I mean, nothing moves healthcare policy like data. And so, thank you for the work that you're doing. It's so important because, otherwise they'll just look and say, oh, you're all hysterical. You're just using anecdotes and you're using these, one-off cases to, try and change policy. And we've got bigger priorities. So thank you for the countless hours you put into that, because it's so important. I think that the hope is that if we just keep pushing the agenda, keep pushing the data forward, showing that it's preventing colorectal cancer cases, it is preventing colorectal cancer deaths, and it's saving money. Like, it's a win-win-win trifecta. And so, to us, it all seems self-evident that we should be lowering the screening age. And so I think that sort of naturally segues in nicely to the question to Dr. Usman Hamid, who, as you heard, is a colorectal cancer surgical oncologist at North York General Hospital where I have my screening colonoscopies. Great experience, highly recommend them. So Dr. Hamid, you're a leading surgical oncologist and advocate for patients who are affected by early age onset colorectal cancer. From your surgical perspective, where do you see the most significant access-related barriers, whether in primary care, imaging, or endoscopy, and how those delay to colorectal cancer patients who are presenting in your clinics?
Thanks, Michael, for having me today. And thanks for the great work by Dr. Parikh, Dr. Brenner, and thanks for Amanda sharing your story as well. I think there are several major challenges for patients accessing screening at the under 50 age group. I mean, I think Dr. Parikh hit the head on the hammer, hit the nail on the hammer when she was talking about awareness, and not only from a patient or public perspective, but also from a provider perspective. When we talk about primary care, and even some of our endoscopists who see these referrals coming through for average risk screening, making sure that they know that there is a rising incidence. And IBS, seeing things like being diagnosed with IBS primarily rather than having it as a diagnosis of exclusion is something that we kind of have to address in terms of the awareness. We're all very proud in Canada to have access to this single payer public healthcare system, but with that system comes huge geographic limitations and variations. In some areas like Toronto, like you elucidated, Michael, like we're very blessed with access in some areas. At North York, we have great access to endoscopy, but that may not necessarily be true in Northern Ontario or in some other provinces. So we have to be aware of, the downside of lowering screening. Even though we all want unlimited access to these resources, it may be taking away spots in the endoscopy clinic or in the hospital clinic for patients who do have symptoms. And a lot of patients that we see that are young onset are symptomatic for a prolonged period of time and without access to that endoscopy suite. So I think it's important to not only address asymptomatic patients, but also to allocate resources from the public healthcare system to expedite and to promote better access and removing the barriers for patients that may have symptoms that are worrisome in general. So, and then the third thing is that the public funding model for hospitals right now may not be great at promoting average risk screening at the hospital setting. Certain provinces actually have funding models that are defunding hospitals for doing more average risk screening. And the purpose of that is to have better access for symptomatic patients, but that would need to be changed if we're going to lower the screening age.
Thanks, Usman. I want to ask you, further to Amanda's point, sometimes we hear that patients are not eligible for screening, and people have even had colonoscopies canceled. My understanding is that non-endoscopist is that in Ontario, there may not actually be funding, like the endoscopist may not be able to get paid for doing a procedure. Is that right, if they don't meet certain criteria?
That's not completely accurate in the sense that the endoscopist will get paid still for the procedure, but hospitals will get paid less if patients are not eligible for screening, number one. Number two, if certain hospitals if hospitals in Ontario are doing a proportion of their colonoscopies that are greater than their target for average risk screening, they actually get less funding from the government. So those are demotivating factors for hospitals and for clinicians to have more asymptomatic patients get screening in certain settings. But it's something that, in somewhere like Toronto, where we have a multitude of outpatient endoscopy clinics popping up because of recent changes in the public policy and different recent changes to the funding models, there are better access, but that does not exist everywhere. So there are downstream ramifications of lowering screening age when patients that are symptomatic and have red flag symptoms can't get a colonoscopy within 6 months in some areas in Canada. So.
Wonderful. And I'm just, Cassandra's been taking some comments and questions from the audience. And so just wanted to emphasize something that Dr. Parikh had said is the difference between screening and diagnostic testing. So for those who are not familiar with the parlance, so Screening is specifically for patients who have no symptoms whatsoever, okay? So if a patient has abdominal pain or they have blood per rectum or their family doctor does a blood test and they have anemia, that is no longer screening. That means that the patient has a symptom and they are being investigated with a diagnostic test. And why that's important is because some tests that are used for screening are not appropriate to use for diagnosis. So if a patient presents with bright red blood per rectum or they're anemic or things like that, it would be absolutely incorrect to do a FIT-based test as the next test, okay? And we see that happen all the time, unfortunately. So FIT is a screening modality that is only appropriate for people of average risk. They do not have a family history. They do not have inflammatory bowel disease. They do not have any of those risk factors, and they do not have any symptoms at this point in time. Diagnostic testing, a colonoscopy is indicated. If you're anemic or you have the symptoms, you need to have diagnosis. And so that is with a colonoscopy or an OGD or whatever is appropriate depending on the actual symptoms that you're having. Okay, just mindful of time and wanting to hear from all the experts. The next person we are speaking to is Dr. Gary Wild, a preeminent gastroenterologist from McGill. I heard the word senior used before, but I don't use the word senior unless, it means something. So preeminent scholar. And so Dr. Wild, we're really excited to have you here and to, get your perspective from your experience in Quebec. For those of you who are not Canadian, Montreal is still in Quebec. It's a different province in Ontario. And I would love your perspective from a GI and endoscopy standpoint. What are the sort of practical considerations, such as, FIT performance, colonoscopy capacity, triage systems, workforce limitations that we need to address in Canada if we're going to be able to lower the screening age?
Yeah, I think the access is really a fundamental issue into the system, and I think that goes Canada-wide. And if I look at the comments made about, say, the Toronto area, where there are a lot of private endoscopy suites that are opening up, these are non-existent for the most part in Quebec. And for the few that do exist, it's completely out of pocket. And most of the workload is focused on indulging the worried well, who have really no symptoms, but are, concerned, etc. Access really relates to access to primary care. Quebec has the fewest number of family physicians per 100,000 population. And we have passed a draconian law called Bill 2 a couple of weeks ago. And I think Ontario is benefiting because there are already 250 people, including gastroenterologists, who are applying to work elsewhere. And one of the key limitations is they are removing the consult fee for gastroenterologists for screening colonoscopies. Now, if I look at it from a primary care standpoint, I got curious a couple of years ago and work 1 to 2 days per month in a family medicine clinic in order to triage and work with family physicians to see if we can fast track those individuals who are young, who have symptoms, aren't deficient anemia, etc. And that really is an important entree into the system, because our provincial entree into the system is a form called AH702. It's a check boxes. And for example, if you're FIT positive, we have to come in within 60 days to perform the colonoscopy. Since the pandemic, over half of the FIT positives were way out of target. And we're still trying to catch up since the pandemic. The unfortunate thing about these triage forms is that family physicians will put, say, somebody who has IBS, they'll mark down rectal bleeding and iron deficiency anemia. So the patient gets into the system ahead of those who in fact are FIT positive or those who are, symptomatic and who really need this. The other thing in terms of the access is that all forms go to the endoscopy administrative support staff in every university hospital and every community hospital. So there they are triaged, and The onus is to fill up our endoscopy times. So we will see half of our endoscopy lists where we're doing colonoscopies on people where really it's a very low priority. So these are really the access issues that we're facing. And I think with respect to family physicians, Osler said it very well. If you listen to the patient long enough, they'll tell you what the problem is. And I think often we're short-circuiting this and saying, oh, well, this is IBS or this is just a hemorrhoid, etc. And I diagnose every year, over 20 patients with early onset colon cancer. What is unique is that with telemedicine, none of them have ever had a physical exam. And the only physical exam they have is just prior to my inserting the colonoscope. And there are a lot of times that I've detected a rectal cancer just, on the day of the actual exam itself. So, these are really access issues. The second issue is we're not training enough gastroenterologists. And should we be looking at other professionals, allied professionals, nurse practitioners to do, say, sigmoidoscopies, physician assistants? Because if we look at the average age of gastroenterologists in the Canada-wide and in Quebec, a lot of them are within my age group and who have been practicing for 30 years or more. So this is a major issue. The other one is that colonoscopy is extremely costly to do in hospital centers. It's limited by the nursing support and endoscopy technician support that we have. And we have been lobbying for many years to have extended hours, including weekends, and in order to even catch up during the pandemic, and that has fallen on deaf ears. So really, this is, it's unfortunate that every year I'm doing colonoscopies on individuals where I'm finding advanced cancers, and then we have to get the system to move very quickly. What's equally unfortunate is that a lot of the cases that I'm diagnosing, their entree into the system is through the emergency room after a 20-hour wait, and then they end up on our consult service fast list. So we're really falling short of the mark in a lot of respects. And it's, polyp detection is really the reason that we're doing this. And, when you look at if you're doing, colonoscopies on people under 40 or under 45, it's going to take 28 individuals to find one advanced adenoma. And we can deal with that advanced adenoma, put the person onto a surveillance program, et cetera, and really prevent colon cancer. So really, it's all about access and availability of endoscopy. Quebec we have really sort of unique issues related to access, but my feeling is that, and my knowledge is that it's really Canada-wide. Yeah.
No, thank you for your insights. And yeah, sorry for what our colleagues like you were going through in Quebec with those recent laws that make zero sense to us. And you're right, we are like we've already had people apply for jobs at our hospital to work. So we're benefiting because we're taking the bright people from Quebec who don't want to work under such silly guidances from the government. So hopefully that all gets sorted out soon. I've got some good questions here from the audience, and I have my thoughts, but again, I want to hear from everybody else. So one of the questions from the audience says, I understand that lowering the screening age to 45 feels quote unquote achievable. However, for me and other late stage colorectal cancer patients in Canada diagnosed between the age of 30 to 40, it feels like an under ask.
Yeah.
For the experts on the panel, what would your quote ideal world screening age be? I wonder if anyone wants to take that. Dr. Parikh, maybe?
I'm happy to take this. I actually mentioned this on our kind of planning call too, is that again, let's acknowledge that 45 was a win, but I hear you. Like many of the patients I see are under 45. I was sharing with the group in the last month. I'm co-managing 2 teenagers with pediatrics. And so I don't know if I have the right answer to that because I do not think even in the US it's tenable to say we're going to start screening everyone at the age of 18. But I think we need to get to a place where we start to better characterize the risk profile of who are the at-risk under 45s. We're not there yet, but I think we will get there in terms of understanding who that patient population is so we can extend the screening. And then I think we need to kind of push the science in terms of, as we talked about, tools at our fingertips that are not colonoscopy is the gold standard. Is it some fit testing early? We all understand the limitations of the blood-based screening modalities, expensive, low advanced adenoma detection rate, but pretty good for cancer detection rate. And so are those other tools that can also help risk stratify who needs to get in for even a diagnostic colo faster? So some of the things, those are some of the things that we're even, evaluating. Now we also have at MGB, we also have wait times for colonoscopy. It's not like we're able to get colonoscopies next day. That lag time is there. And so can we use these tools to also figure out who gets to jump the line a little bit, even in a screening population? So I know that's not the answer you wanted. I think my bias is like, I see so many younger, and of course, like everyone, maybe at 18, you just get it done. But I know that's not tenable for a health system at all. So, can we all work together to try to understand risk? The other kind of public service announcement I like to, I think, talk to our gastroenterologist about is, if you're even diagnosing high risk adenomas in a, not a cancer in a 48-year-old or a 52-year-old, make sure that they inform their first degree relatives, because from my perspective, a high risk adenoma is a cancer equivalent. And so if you somehow found out your dad had a high risk adenoma, had never had cancer at 50, then you're actually eligible for your colonoscopy at 40. So if we can work with our gastroenterology colleagues, Dr. Wild too, to like figure out how do we educate even around the high risk adenomas, and educating those first degree family members, I think that also helps a little bit, because adenomas are often just written off. And I think they shouldn't be.
Yeah, I mean, it's a great point. I mean, every case of cancer that we see in our clinic is frustrating, but the most frustrating ones are people who had a family history and they've never had a colonoscopy. And it's just infuriating to hear about that. And you're absolutely right. Like, that's a cancer. Most people think, oh no, they just had a polyp. It was nothing, and they have no idea that they could potentially be eligible for screening as a result. So very, very important. I think that one of the things we're seeing, and I wonder if the other panelists are seeing it, we're getting a lot of questions now at Sunnybrook about the new blood-based screening tests. So in Canada, we have access to the Gallieri screening test, which is expensive. I think in Canada, it's $1,800, and it screens for 50 different cancers. It's currently available for people over the age of 50. And maybe there are innovative solutions. Maybe that's not it, but if we could come up with a blood-based test or a stool-based test, that is much more sensitive for detecting adenomas, like that would be wonderful, and maybe would address some of the capacity issues that we have. Looking to the questions, I know we've got limited time, maybe 10 minutes left. So there's some comments from healthcare providers in the crowd. Okay, good. We've got some healthcare providers wanting to know how they can help. What opportunities are available for us to engage a health force that is ready to help? What needs to be done to support continual professional development for healthcare practitioners? Maybe Amanda, from your perspective, having gone through this with your cousin, what do you think could potentially be done to, go back to a time when the symptoms weren't being taken seriously or weren't given the urgency that they deserved?
I think it goes back to the same conversations that we've been having really around awareness, right? I think we heard so often from our doctors, mine as well as Adam's, that it's not likely. It's not likely. And there was a real lack of understanding that was a possible risk. And I think it is that awareness and that understanding at the family physician level to say that this is an issue. And it's, to Dr. Parikh's point, it might be small and it might be, you're not going to always find the same symptoms in people across the board, but to just have it in the back of your mind that this is an issue and that this is a rising concern. To my earlier point, there's so much to know as a family physician and there's so much knowledge. And I think it's just passing along this message, passing along to your colleagues, having these conversations to say that this is, that this is really a trend that we're seeing across the country, and to pay attention to those symptoms and to consider it, that it might not always be the diagnosis, but to consider it as a possibility.
Absolutely well said. So the next question came in, does a competitive national environment for medical professionals paired with provincial policy differences create a system-designed barrier for patients? So maybe I'll ask that towards Darren. You've done a lot of work, pan-Canadian work. Do you notice any differences in the engagement or the appetite for change across provinces, or has anyone been more open to or more resistant to the data that you've produced, that you've seen?
Yeah, absolutely. I think Dr. Wild highlighted very well that there are challenges in many places to meet the current demands. And so I think there is a certain openness in different places where they might have more resources, more capacity, or the geography is such that it's easier to administer a program that can reach many, or if not all. So certainly there are differences in even the test thresholds that are used for the same tests. And so there's all kinds of differences behind the scenes that are happening. And so what, that really translates into, it's really hard to come up with a unified message because there's such a difference in resources and the way the programs work in each province. So I think it is a barrier, but it's definitely not insurmountable. We have, success right now in the 50 to 74. So I think it can just be expanded upon, accepting that there will be differences and there will be challenges, but that's just part of having a federated system.
Thank you, Darren. There's a question: which tests healthcare providers can order the Galleri testing? So that's that private proprietary test. My knowledge right now is it's only can be ordered at certain clinics. I was told that MedCan, which is a Toronto-based organization, has exclusive rights to order it, and then there's this other private-based clinic. Right now, just as to my knowledge, I've never ordered it. I don't think just a routine clinician can. But I would just encourage you to Google that. It's quite new. Yeah, when I just look at it now, I'm pretty sure it's only available at MedCan for patients over the age of 50. But the team at CRAN can also look into this and provide some feedback to that as well. Good question. So some of the things that I'm just sort of reflecting on are the national challenges that we have. We always do think that, healthcare is supposed to be portable and, if we should be sharing resources. One of the things that I find crazy is we run this hepatic arterial infusion pump program in Ontario, and we are not allowed to take patients from outside of Ontario. It makes no sense. It makes zero sense to me. I would treat a patient no matter where they're coming from. But the funding structure says that we can only treat Ontario patients, which is crazy. We live in Canada. We're one country. You should be able to treat people from wherever they're from. And so I do think that to this participant's question, there are these sort of not a lack of alignment between the provincial governments, and we need to remember that we're one Canada and that we should be working together and sharing strategies and best practices and resources to get patients access to the diagnoses and the treatments that they need. I guess I would go next to Dr. Wild. In your experience, as a gastroenterologist, having done this for many years now, have you seen shifts in practice? Have you seen patients coming more often requesting screening colonoscopy?
Absolutely, and it's quite interesting. Humans have a phenomenon known as causal attributions, and people have attributional styles. Their causal attributions, maybe years ago, they would have said my rectal bleeding is from hemorrhoids. But now, with more and more information, they're seeking out information and want access to colonoscopy much quicker. The other interesting referral base we're getting from are pharmacists, because I get routinely 1 or 2 calls a month from pharmacists, and they'll say, we have this patient, and they were asking questions and said they had rectal bleeding, and we know that you're a center for screening. Can we fax you over a request? And we pick up many patients that way. The other thing I can say in terms of shifting trends is that since the FIT test, every time I do a colonoscopy on somebody with a positive FIT test, I find something. And more often than not, it's a polyp. And about 20 to 30% of the time, there's high-grade dysplasia within that polyp. Some of them are very complex polyps, and we refer for endoscopic submucosal dissection, but the cases are becoming increasingly complex. And that I think it's a Canada-wide phenomenon. Yeah.
Yeah, I mean it's interesting to hear that, and then again, fit tests are good tests. There's a very, very large study that came out, I believe it was called Coloprev, that was published in the Lancet, that looked at fit testing, and fit testing is non-inferior to colorectal cancer, to colonoscopy. And it's readily accessible. Anyone can do it. There's very few system resources. So, I do strongly believe in colonoscopy as the gold standard diagnostic test. But if we're working within the system we're working in, I think everyone should have access to fit testing. It's easy to do. It's a highly sensitive test overall, and it can identify precursor lesions. As those, for patients in the audience, we're very interested in identifying polyps, particularly advanced polyps, early, because those can be removed. Those are precursors to cancer. If you can remove them, you can prevent the development of a cancer. That's why we have screening programs for colorectal cancer in the first place. And so it's critical that we identify these precursors.
And in Ontario, it's $75, which is cheaper than a cell phone bill for the month. So, if the government isn't willing to fund those tests for patients, under 50, essentially right now, maybe we could fund it ourselves as patients. And I know that we live in a public healthcare system and we're worried about equity, but $75 is not a huge ask for someone to access something that could be life-saving.
That's a great point. That's a great point. I didn't know it was that. That's a lot of money for some people, but that's relatively cheap overall, as you say. And I think, one of the things that's interesting about the breast screening program is you don't need a referral. And so I think to Dr. Wild's point about a pharmacist being able to refer in, I don't know if that's allowed in Ontario, but I think we need to eliminate all barriers. Like, I think that if someone wants to have a screening fit or a screening colonoscopy, they should go to the Cancer Care Ontario website or whatever website it is, read about, the test, the limitations, how to perform it, what the follow-up would be. And if they want a test, they should be able to get a test. Like, I think it's that simple. And I think it speaks to the question from the audience before of, we're arguing for age 45, but ideally anyone who wants a test should be able to get a test, provided there's appropriate education and guidance. And so I guess the final question that would go to you, Usman, I haven't asked you a question. If we were to implement some sort of system where patients could self-refer for screening, what sort of things besides, access issues do you foresee challenges could be? Do you think that maybe, people could select the inappropriate screening test, or what kind of challenges could we encounter?
So I think if they could self-refer for screening, I think a fit test would probably be the best way to do it as the first test, so that we're not scoping, like Dr. Wild was saying, the healthy patients that are just worried about, having something bad, but they're low risk, so that we don't divert resources away for the patients that are highest risk. So that's what I was getting at with the fit test being so affordable. If we would, like right now in Ontario, if you're under 50 and you ask for a fit test and you even collect the fit test and send it to the lab will throw it out if you're not part of the screening age, which is mind-boggling. So opening up that as access for patients that are younger. And I don't know if it really needs to be a minimum age, if it's over 20 even, for something that affordable.
Yeah. No, I mean, it's amazing. And to Dr. Wild's point before that, some practitioners are writing down false information like bleeding per rectum because they want to get their patients in for for colonoscopies, and they realize if they don't write the keywords they're not going to get that, but it is taking the place of people who do need to be urgently seen. So I think what I'm hearing from all the panelists today is that we all are in agreement that we need to lower the screening age, we need to improve access to screening modalities and diagnostic modalities. We need to have appropriate resources in place to reflect the rising incidence of early age onset colorectal cancer. We need to support our patients, we need to support their families, and we need to support our colleagues, because not lost in all of this is that our doctors and our colleagues are working so incredibly hard within strained resources in the system. That includes our family doctors, our nurse practitioners, our gastroenterologists, our surgeons, and medical oncologists, and everyone's trying their very best within a system that's not appropriately resourced for the needs. So, thank you. I recognize we're coming up on time. I want to say thank you to CRAN for organizing the session. Thank you to my esteemed colleagues for this panel. I've learned a lot. I think it's been really a wonderful, insightful discussion. And, I look forward to working with you all in the future to actually lower the screening age in Canada and make some real change. So, with that, I'll say thank you to my colleagues, and I'll hand it back to you, Cassandra.
Thank you. Oh my goodness, what a great discussion this was. It is clear, at least to me, that the alarm bells are going off, and I hope some decision makers are listening today. CRAN will continue to push for the screening age to be lowered, and we are so privileged to have the support of experts such as these wonderful panelists and the broader patient community as we forge ahead with our efforts. We will move to the next session now. I will just add a technical note that depending on the browser that you are utilizing, you may just need to refresh your browser between sessions, and we'll see you there.